Thank you very much, Dr. Parenti. Well, it appears that diagnosis isn't that straightforward, but hopefully treatment will be. Today, here to talk about early treatment is Dr. Tony Leonetti from Southern New Jersey. Dr. Leonetti is a family practitioner and he lives in an endemic area and practices in an endemic area. Dr. Leonetti.
Thank you. Really have to thank Dr. Parenti for bringing those beautiful slides of culture-confirmed erythema migrans. The talk that I have today is on early localized Lyme disease. Dr. Ligner will be presenting disseminated disease, and it's important to realize that early localized Lyme disease is really disease that is occurring in the skin and maybe in the very early phase of hematogenous dissemination when the organism is first entering our bodies. It's important to note that in Dr. Parenti's slides that EM has many manifestations and that it's very difficult to just say that EM is just one particular pathognomonic lesion. It is important to also note that various medical conditions consistent with Lyme borreliosis were described in North America and Europe from the late 1800s. In 1883, Buchwald in Germany was first to describe acrodermatitis chronica atropicans. In 1921, Afzelius described the lesion that we call erythema chronica migrans. In 1895, in New York City, two dermatologists independently reported on a number of German immigrants who had skin lesions similar to the cases reported by Dr. Buchwald. In 1944, Dr. Bainworth published his findings about the neurological syndrome, which now bears his name. It was not until 1975 that the association of erythema migrans with arthritis after tick bites in a cluster of cases of what was thought to be juvenile rheumatoid arthritis was reported in Old Lyme, Connecticut by Dr. Alan Steer and his colleagues. The most important discovery was made by Dr. Willy Bergdorfer et al., who isolated the causative agent, Borrelia burgdorferi, thus linking the cause of what in those patients in Connecticut was characterized as juvenile rheumatoid arthritis was in fact a bacterial infectious disease. Additionally, it was found to be antibiotic responsive. It must also be documented that in the 1990s there have been tremendous advances in both the basic scientific knowledge that exists about Lyme borreliosis and the tools used in its evaluation. Especially significant has been the recent publication of the genome of Borrelia burgdorferi by the Institute for Genomic Research, the three-dimensional view of outer surface protein A structure provided by Dr. Dunn and his colleagues at Brookhaven National Laboratory, the development of direct detection testing such as the polymerase chain reaction test, and the urine antigen test, and more specific and sensitive serological tests, which are now either clinically available or are being developed. Other relatively new discoveries include co-infection issues with other organisms, as has been described by the other speakers, including viral encephalitis in Europe, babesiosis, and HGE and HME in the United States. I will not be discussing these co-infection issues as is outside of the scope of my discussion and would take a heck of a lot longer to put together and more time than we have. Of great significance is the development of a possibly safe and efficacious vaccine for the prevention of clinical human Lyme borreliosis. Humans in North America are infected almost exclusively by the bite of the common deer tick and to a lesser degree the Lone Star tick. Other hemophaginous flies, mosquitoes, spiders have been experimentally shown to be capable of infestation with Borrelia burgdorferi. However, they account for a very occasional case of Lyme borreliosis. Only the ticks previously mentioned are significant vectors for the transmission of this disease to humans. Infection after tick bite has been reported to be as low as 1% in the United States and as high as 11% in a study in Russia. It is interesting to note that an abstract that was published in Arthritis and Rheumatism in 1993 studied 179 individuals in a door-to-door study in an area endemic for Lyme borreliosis in New Jersey using a highly specific and sensitive PCR. This study revealed a 14% incidence of Borrelia burgdorferi spirochetinea in late spring. Very importantly, none of these patients showed evidence of clinically active Lyme disease and did not even report tick bites. It is well recognized that due to the small size of the tick and its painless attachment. Most patients do not recall that they were bitten. In the medical literature, Dr. David Dennis has been cited as reporting that 63% of CDC-validated cases of Lyme borreliosis in the United States during the time period of 1991-92 presented with erythema migrans. This conversely represents the fact that 30% of these cases did not present, or it just simply wasn't noticed that they did have erythema migrans. As I said, Dr. Parenti illustrated the interesting manifestations of this rash, and clinically, healthcare providers are challenged with seeing rashes that are left by insects which are not pathognomonic for Lyme disease. And they really need to elucidate other aspects of the rash which may help separate it from other insect bites. One important aspect to note is that erythema migrans rash does not develop immediately at the inception of the tick bite. Usually when you get immediate rashes with the tick bite, it may be due to allergic reactions to the tick, components of the tick's mouthpiece, or to the saliva. Erythema migrans will usually develop somewhere within 3 days to a little more than 2 weeks after the inception of the tick bite, and will resolve within a few weeks to a few months. Occasionally, it will develop at a site away from the actual tick bite and may even appear as multiple lesions. When that occurs, there's more concern that there has been more significant hematogenous spread and that we really are dealing with disseminated disease. As a rule, these rashes may be mildly painful, if painful at all. They're usually a little pruritic, but severely painful rashes and necrotic rashes are more associated with spider bites. Cultures of true erythema migrans rashes are successful under the best of conditions up to 80% of the time, but they may take a while to get back results, anywhere from 4 to 8 weeks at times, for growth and identification. Using this technology, it may be difficult to make an immediate decision, obviously, when you see a patient, if the rash that you're seeing is truly EM. Let's go to the next slide. Diagnostic manifestations of early Lyme disease include, I didn't put it on the slide here, but fever is an important presentation. It can be low grade or it can be hectic. It is not a specific finding, as the other tick-borne diseases that we were talking about also manifest this. Musculoskeletal manifestations can include myalgia and arthralgia. The arthralgia may also be a frank arthritis. Constitutional symptoms of fatigue, malaise, flu-like sensations, and headache occur in the majority of cases. Occasionally, there's regional or generalized lymphadenopathy. There can be elevated liver function tests, but these are never very severe, in the range of 1 to 2 times normal. There is no specific pattern of liver function abnormality. The eyes can present with mild to moderate conjunctivitis. As Dr. Schell had discussed, the diagnostic testing with Lyme disease is rather treacherous. There really is no good immunological response that we can measure in the first few days of illness. It may take up to 4 days for the body's B cells to start making antibodies, and these may be taken up by antigen, and therefore these tests may not become positive if the testing will be positive until at least 2 weeks or so after the inception of the disease. The ASTPHLD has recommended that with positive tests that they should be confirmed with a Lyme Western blot to rule out false positives. If testing is performed and it is performed in the acute phase of the disease and it is positive within the first few days, one has to consider that the patient has been previously infected or has been infected longer than we thought. If it is negative and becomes positive, convalescent titers should be obtained somewhere 4 to 8 weeks after the tick bite and compared. And if we have a test going from positive to negative, negative to positive rather, that at that time it can be considered that this patient may have a confirmed case of Lyme disease by serological testing. Polymerase chain reaction testing is a newer technique. It is not generally available. Laboratories that are doing this test really need to be sure that they have a validated methodology, that their positive and negative controls are run concurrently with the specimen, and you really need to have this done at a lab where you can speak with the lab personnel and lab director to be sure that if you get a positive test, that you are not dealing with a false positive test, which can occur from contamination of the specimen during processing. It seems the polymerase chain reaction test can be positive in the first few weeks of illness. It is not a recommended test. It is still experimental. It is difficult to obtain a good quality test, and I put it here basically because I think in the near future we will be including it more and more as a test that will be generally recommended, especially in early stages of disease. A very important thing I think that we have to bring out is the fact that all cases of patients with erythema migrans should be reported to your county health department. It is important for us to know how many cases meet the surveillance criteria. This surveillance criteria is not to be used for the clinical diagnosis of disease, however. The erythema migrans rash that we're talking about for the CDC definition of surveillance criteria needs to be 5 centimeters or greater. As Dr. Parenti has shown, erythema migrans rashes can be much smaller than this, and on a clinical basis, any rash that is highly suspicious should be considered as a possible EM. Possibly we should obtain cultures for confirmation. Those patients should probably be tested, have serological testing, have acute and convalescent titers performed, and should be treated promptly. The CDC surveillance criteria also states that a person with at least one late manifestation of disease and laboratory confirmation of infection, I'm sure Dr. Ligner will go thoroughly into those later manifestations of disease. But once again, I must stress, let's all try to be sure to report all cases to the county health department. In early disease, treatment is rather straightforward. The cheapest antibiotic to use in the group is doxycycline at 100 milligrams PO/BID for 28 days for 4 weeks, or amoxicillin 500 milligrams PO/TID for 4 weeks. Doxycycline has distinct advantages in questions where there may be co-infection or other diseases such as Rocky Mountain spotted fever or unigranulocytic ehrlichiosis, as those diseases do not respond to penicillin-type antibiotics. Cefuroxime oxytocin has the distinction of being the only drug formally approved by the FDA for the treatment of Lyme disease. It's approved for adults and for children greater than 12 years old at a dosage of 500 milligrams PO/BID for 20 days, and it was considered equally effective to doxycycline at 100 milligrams, and in their studies it was done at a dosage of 3 times a day. Azithromycin and clarithromycin have both been shown to be effective in studies against Lyme disease, though they are not considered first-line drugs. Treatment of early disease in children is somewhat similar, and we eliminate doxycycline because of the known problems with teeth in the younger age group. Amoxicillin at a dosage of 25 to 50 milligrams per kilogram per day by mouth 3 times a day in divided dosages for 28 days is the method preferred. For children greater than 12 years old, Ceftin at 250 to 500 milligrams PO/BID for 20 days is considered, and Zithromax can be given at a dosage of 5 to 10 milligrams per kilogram per day as single doses for 28 days. One thing I thought I'd discuss are questions of treatment failures. Patients who have persistent erythema migrans rashes within a week or two after continuation of therapy. Even further than that, people who start to develop more constitutional symptoms of Lyme disease, people who seem to get better and then have recurrent EM rashes or develop other constitutional symptoms at that point. It's a difficult situation. Those people should definitely be tested. If they have questions of central nervous system involvement, they should receive lumbar punctures and be fully tested. And if they do have evidence that they are a treatment failure to oral antibiotics, they should be treated with ceftriaxone or Rocephin at a dosage of 2 grams a day for 28 days. In children, it's a similar situation, of course, but the dosage of ceftriaxone is 75 to 100 milligrams per kilogram per day as single doses, not to exceed 2 grams a day for 28 days. now we'll get into a controversial area, prophylaxis of tick bites. There is no doubt that the literature shows that in various studies that there is a 1.2% incidence of developing Lyme disease from tick bites. The issue that occurs that in some endemic areas, this may be higher. As I mentioned, that other study, there are a good number of people who may have tick bites, have transmission by other means. They may have super-infected ticks. They may have improper removal of the tick. They may have regurgitation of the tick contents into the wound, or frankly, the tick might just be crushed or broken off, or even feces from the tick may contain the organism and infect the wound area. It needs to be considered also the duration of tick attachment. Ticks that are attached for more than 24 to 48 hours, in endemic areas, it would be reasonable to consider prophylaxis in those patients. A recent study performed by the Maryland Department of Health and reported in JAMA by Alan Fix et al. Reported on about 232 patients who had a diagnosis of tick bite, Lyme disease, or probable Lyme disease. What was very interesting is that they treated 70 of the patients for tick bites. None of them developed Lyme disease in that group, nor did the other people who just had tick bites and were not treated for Lyme disease. However, there were no adverse reactions to the medications that were used. And additionally, one of the most interesting things in the study is that the whole study cost $48,000 in terms of the cost of management of these 232 people. The cost of managing 5 people for late-stage Lyme disease in that study accounted for more than 60% of the total cost of the study. This is an important factor to consider because none of those 5 people in the study had developed any early symptoms of Lyme disease. And their first symptom of Lyme disease was neurological Lyme disease. So I think on a cost basis, not considering possible adverse reactions, and that this study actually was not really geared at studying prophylaxis in a placebo-controlled fashion, it does suggest that further studies need to be done and that the verdict's not in on prophylaxis in endemic areas yet. In areas that are not endemic, I think that a watch and wait approach may be reasonable. Sending ticks out for testing might even be reasonable. But at this time, I would recommend that in endemic areas that prophylaxis be employed. In summation, avoid treatment failures by the timely institution of oral antibiotic therapy. When patients call you with tick bites and rashes, see them right away. Make sure that your staff puts them on the schedule immediately so that they're seen, if possible, even the same day. Educate your patients about tick bites, proper tick removal, and signs of early and late Lyme borreliosis. Maintain surveillance on affected patients. Patients who have Lyme disease should not just be given their therapy and told that they are now cured. They need to fully understand what constitutes later symptoms of Lyme disease and what treatment failure may consist of. In addition, it may be helpful in some practices, if it is not too onerous for their staff, to have follow-up phone calls over the course of a year to be sure that these people are well. And lastly, very importantly, work up all possible treatment failures as described and as Dr. Ligner will describe, and report all patients to your county health department who meet the CSTE CDC case definition criteria for Lyme disease so that we can properly track the true endemicity of this disease in the areas involved. Thank you very much.
Thank you, Dr. Leonetti. Our next speaker is Dr. Kenneth Wiegner, an internal medicine specialist who practices in a highly endemic area of Westchester, New York. He'll be talking about treatment of disseminated disease. Dr. Wiegner.
Thank you very much. I'd like to thank the sponsors of this meeting for inviting me, the Lyme Disease Foundation, the Illinois Department of Health, the Illinois Academy of Family Physicians, Cook County Department of Health, and the sponsor for this event, SmithKline Beecham. The prior speakers have laid the groundwork for what I'm going to say, which is dealing with disseminated disease. Dissemination refers to movement of the Lyme disease organism from the site of entry into the host to remote sites within the body. This may be hematogenous, it may be via lymphatics, or by direct invasion along tissue planes. Dr. Klimpner has demonstrated that there may be a role for plasminogen activation, which facilitates direct tissue plane invasion. We do not know the minimum time from inoculation to the skin to dissemination. There is evidence that it may be within days and possibly earlier than that. Dissemination may set the stage for chronicity with constitutional and multi-system symptomatology and late organ involvement. Also, we know that intracellularity has been demonstrated in vitro. As far as I know, this has not yet been confirmed in human beings, but it stands to reason that if it happens in vitro, it may very likely happen in human beings, and this also may help set the stage both for chronicity and for refractoriness to antibiotic therapy. The Centers for Disease Control has always emphasized that the diagnosis of Lyme disease is a clinical diagnosis with laboratory data being supportive only. Also, to the family physicians who may be listening to this, I want to urge to them that it is essential to set aside adequate time to evaluate patients presenting for possible disseminated or late Lyme disease. In our practice, we have found that a minimum of 2 hours is necessary, and sometimes we find that that is actually not enough time to get a thorough history and perform careful physical examination and then discuss the approach to further evaluation and or treatment if appropriate. It's always important, even if you're seeing patients with late disease, to ask about any history of rash that in retrospect may have signified erythema migrans, and also whether they have had a tick bite at any time in their life. Unless you ask the question and patients begin to probe their memories, there may be, in fact, remote times when they did have a rash, but they didn't understand the significance of it. Also, it's important to understand that the spectrum of illness of Lyme disease is expanding, and the limits of the manifestations of Lyme disease are not completely known, so that we must adopt an open-mindedness in considering what may or may not be Lyme disease. Also, correct diagnosis requires a good understanding of Lyme disease, so you have to prepare yourself as a physician, and also it requires a good general medical knowledge because there is a potentially very broad differential diagnosis considering the many different manifestations that Lyme disease may show. It is very important to ask a very detailed geographic history. And also, if you consider that most human beings in the course of their lives do have opportunities for exposures to ticks. If you go back and question them throughout their whole life, have they gone to summer camp? Have they gone to the mountains, to the shore? Have they visited Lyme endemic areas? And it's also very important to ask them about both vocational and avocational risk that would put them in situations where they would have potential risk of exposure to ticks. Also, it's very important to bear in mind that a low inoculum of spirochetes may not present right away with clinical symptomatology, and it may take months or even years for there to be enough body burden of infection of spirochetes to present with clinical symptomatology. For example, the study that Dr. Leonetti just referred to, where the first sign of Lyme disease was neurologic Lyme without any of the early markers for it. Also, once clinical manifestations are present, it is a very common experience for patients, unfortunately, to go for months or sometimes years and sometimes having to visit many physicians to actually get a diagnosis. So there can be quite a bit of delay during which time both direct and immune-mediated injury can occur. One of the key things to consider in looking at a patient with later Lyme disease or disseminated Lyme disease is that typically there are multi-system symptoms that evolve over time. There often are constitutional complaints which may seem nonspecific, but if you take them together as a gestalt, after you see numbers of patients like this, it is fairly characteristic. And a tip-off is that this will often be occurring in patients who previously were healthy. They were not going to doctors with multiple complaints. So if something happened at a very discrete point in time. These symptoms can include fatigue, arthralgias, and myalgias, which often are migratory, cervicalgia or neck pain, which is actually one of the most common symptoms that patients with Lyme disease report, recurring low-grade fever, night or day sweats, recurring sore throat and swollen glands, paresthesias, sleep disturbance, enthesitis or inflammation where muscles insert to bone, panic attacks, anxiety, cognitive difficulties, mood disturbance. A lot of them report just what they say is a kind of a sick feeling that they can't otherwise describe, malaise, so to speak, and often these symptoms will be cyclic. Also, although certainly patients with certain disseminated Lyme will have physical signs on exam, a lot of patients may not have physical signs, so they may look well. Nonetheless, these patients can virtually overwhelm the physician with a veritable blizzard of symptoms, so that, you can almost sense that there's this wall coming down and that these patients are strictly psychosomatic. However, when you see many numbers of patients who report a similar kind of multi-system symptoms, one begins to realize that this is actually due to organic disease. Occasionally, patients may present with a single late manifestation so that they will lack the more typical multi-system flavor. I think I skipped a slide here, or two. Okay, I'm going to go through some of the organ systems that may be involved in late disease. And first I'm going to discuss the central nervous system, which actually, in my practice, comprises a lot of the late morbidity of the disease. And the list that I have here is by no means inclusive. And I'm just going to run through them very quickly. And it's almost any level of the neuraxis can be involved, from a meningitis, meningoencephalitis, meningoencephalomyelitis, myelopathies, transverse myelitis, hemiparesis, paraparesis, spastic para and tetraparesis, motor neuron disease, extrapyramidal syndromes and choreiform syndromes, locked-in state, coma, progressive leukoencephalopathies, multiple sclerosis-like syndromes, seizure disorders, cerebral atrophy, organic brain syndromes and dementia, encephalopathy, neuropsychiatric syndromes with psychoses, obsessive-compulsive disorder, depression, mania, bipolar disorders, and other psychiatric symptoms that Dr. Fallon, I'm sure, will go into. Cranial nerve palsies, involving any cranial nerve and sometimes involving multiple cranial nerves, radiculoneuritis, sciatica-like syndromes, neurogenic bladder. Dysesthesias and paresthesias, which often don't have a typical nerve distribution. Also, there can be autonomic nervous system dysfunction, including cardiogenic syncope and vasodepressor syncope. We've seen a lot of patients with abdominal bloating, which we presume, although we don't know for sure, probably has something to do with the autonomic innervation of the gastrointestinal tract. The organs of special sense can be involved with tinnitus, balance disturbance, vertigo, hyperacusis, which can be extremely severe and very debilitating and limiting, and frank hearing loss. Regarding the eye, virtually any structure of the eye can be involved, from conjunctivitis, keratitis, uveitis, optic neuritis, retinitis, and retinal vasculitis, cataract formation, retrobulbar myositis, and optic cortical cerebritis. So needless to say, this can be a very challenging disease with all of these various symptoms. Obviously, they're not all going to occur in one person, but you have to bear in mind the possibility, at least think of Lyme as a possible consideration in the differential diagnosis. Regarding the musculoskeletal system, one can have arthralgias without objective signs, and in fact, Dr. Mario Philippe, who has a monkey model, rhesus monkey model of Lyme, At sacrifice, these monkeys will show spirochetes in their joints, but will not have any, may not have gross synovitis or arthritis. So, and yet this may cause symptoms and pain. There can be frank arthritis with synovitis and effusions, which can be sometimes very troublesome and difficult to resolve. There can be myositis. There can be myopathy, which I think is underappreciated. Some of these patients can have severe muscle weakness that is that we don't really understand the mechanism by which this is occurring. They can have painful myalgias. They can have fibromyalgia-like syndromes. They can have muscle fasciculation, fasciitis, and again, enthesitis. The genitourinary system can be involved with neurogenic bladder. There can be interstitial cystitis. And in dogs, there have been reports of renal damage with glomerulonephritis. I am not yet aware of any such cases having been reported in human beings, but it's something worth keeping one's eye open for to see if it might occur in humans. As far as endocrine involvement, in my practice, we've seen a fair number of patients who've had thyroiditis, although we are not aware of any reports in the literature describing this. Many patients with Lyme will have diminished libido. We don't know whether this is on just because of constitutional effects of infection, whether it's on a hypothalamic basis or due to end organ involvement such as orchitis. Many women having Lyme disease will report intensified symptomatology in and around their menstrual cycle. There can be a wide variety of cardiac manifestations, including dysrhythmias, heart block, various types of extrasystoles. There can be autonomic dysfunction, as I mentioned before, with cardiogenic syncope. There can be myopericarditis progressing to cardiomyopathy, and there was a beautiful article in the New England Journal of Medicine a few years back by Stanek from Austria showing a biopsy-proven case of cardiomyopathy with spirochetes demonstrated, and also I believe it was culture positive as well. And this can also progress to congestive heart failure. There was an interesting study, which was not really further followed up by Jesse Goodman, showing an inordinate percentage of seropositivity in patients eventuating in cardiac transplantation due to chronic congestive heart failure out in Minnesota. As far as gastrointestinal manifestations, we also feel that this has been underrepresented in the literature. It is very common in childhood Lyme for there to be complaints of abdominal pain. As I said before, there's a lot of reports of abdominal bloating. It's our impression, although again I don't think there's much in the literature, if anything, on gastroesophageal reflux disease. We have seen patients where there seemed to be an irritable bowel or colitis-like picture, again not well reported in the literature. There are reports in literature of Lyme hepatitis, biopsy proven. And one thing I didn't mention, which I should have, is, which Dr. Leonetti alluded to, is that late skin manifestations, acrodermatitis chronica atropicans, which is a peculiar kind of thinning of the skin of the distal extremities as a result of residence in the skin for sometimes decades of the Lyme disease organism. Differential diagnosis that needs to be considered. Again, this is a multi-system illness. There aren't that many things which will produce this kind of multi-system disorder. There are not that many things, for example, that will have a combination of both joint involvement and neurologic involvement, and that often is a tip-off. Obviously, there is the issue of connective tissue diseases, syphilis, sarcoidosis, chronic viral infections such as hepatitis, HIV, CMV, and parvovirus, tuberculosis, brucellosis, relapsing fever, various parasitic diseases, and I'm sure there are other things that people could think of. Also, you have to distinguish it from lupus itself and rheumatoid arthritis, the chronic fatigue syndrome, and idiopathic fibromyalgia, but I also want to say that Lyme itself can very much mimic these disorders that I just mentioned. We've had patients who have high titers of rheumatoid factor, but also have serologic evidence on Western blotting of Lyme disease, where the rheumatoid factor, have one patient that we really ought to report, where the rheumatoid factor, it's almost like a yo-yo. You treat them with antibiotics, the rheumatoid factor goes down, you stop their treatment and the rheumatoid factor and the symptoms go up, and we have a number of patients like this. Also, there can be lupus-like presentations, and many patients with Lyme will have, just because of their chronic infection, nonspecific positivity of their ANA with a variety of patterns, most commonly diffuse, but sometimes some of the other patterns may be seen. And we have also had a few patients in our practice who had what is supposed to be pathognomonic for lupus, that is anti-double-stranded DNA antibodies. We've seen a few patients with Lyme who show this, and sometimes where the anti-double-stranded DNA antibodies will resolve with intensive antibiotic therapy. Also, both Lyme and lupus can show the presence of C1q immune complexes, which is worth bearing in mind. Patients can have serositis, pericarditis that look very much like lupus, but in fact may be Lyme disease. I want to discuss laboratory diagnosis. There's been a great deal of emphasis how horrible it is that there are all these false positive ELISAs going around, and all these patients are getting needless treatment for a disease they don't have. And there's been allegation, or there's been it has been claimed that late Lyme disease is almost invariably seropositive. That does not square with my experience, and from my perspective, the problem of false negativity is a much more serious problem than the problem of false positivity. If you have a false positive, then the worst that happens is a patient who doesn't need treatment gets treatment that they don't need. On the other hand, with false negativity, patients who may really have the illness are not going to get diagnosed and treated, with the resultant, unfortunately, severe, possibly very severe morbidity. The issue of seronegativity, is it a real phenomenon or is it bogus? If you look at many of the culture-proven cases of Lyme disease, including late cases, they often are occurring in the literature in seronegative patients. I set my nurse practitioner, Janice Kochivar, to the task of looking at the last quarter of 1996 in our practice, which specializes in the diagnosis and treatment of Lyme disease. And what we found was that, and also we don't do two-tier testing. We kind of shotgun it and do both ELISA and Western blot simultaneously. We found that 16% of our patients new to our practice in that quarter of the year had both positive ELISAs and positive Western blots, whereas 21% of our patients had dead negative ELISAs and fully diagnostic IgG or IgM Western blots. Many other patients had Western blots that we would regard as suspicious, although not fully diagnostic. I'd also like to emphasize for the clinicians and family practitioners, when you request a Western blot, always insist on having all bands present reported so that you can interpret the Western blot yourself. For reasons known only to asphodel and the CDC, two of the most critical bands on Western blotting, 31 corresponding to outer surface protein A and 34 corresponding to outer surface protein B, very, very highly specific bands, are omitted from the CDC criteria of reportable bands, and that's a very serious error, in my opinion. I just have a list here of tests that we have found useful in our practice, and again, some people might not regard it as cost-effective. We have found it necessary to basically do all of these tests when patients are being evaluated for possible Lyme disease. Sedimentation rate, which should be done in the office. If it's beyond 2 hours from blood drawing, the sed rate becomes inaccurate, so it's kind of useless to send off to your reference laboratory for sedimentation rate. C-reactive protein, Lyme, ELISA, and Western blot. We routinely, since there has been a lot of studies showing that you cannot rely on results from a single laboratory, we routinely send to 2 different good laboratories and request both ELISA and Western blot, and again, always insist that all bands present be reported. CBC with diff, chemistry profile, ANA. If that's positive, then we would go on to do anti-double-stranded DNA and anti-extractable nuclear antigen antibodies. We do FTA absorbed. If that's positive, we will do an MHATP, which can be a discriminator between syphilis and other spirochetal diseases causing cross-reactivity in the FTA. Thyroid function tests with a TSH, angiotensin converting enzyme, anticardiolipin antibodies, and quantitative immunoglobulins for many patients with Lyme disease will show polyclonal IgM elevations, occasionally polyclonal IgG elevations. Obviously, this is not specific for Lyme, but it gives you a clue that there is something that is stimulating the immune response. Also, whenever we have the opportunity to do so, when tissue is available, sometimes we will do biopsies ourselves. We will try to get a histologic demonstration of spirochetes by silver staining. Unfortunately, there are very few pathologists in the country who have really specialized in the art and science of histologic examination for B. burgdorferi. Also, you could do electron microscopy, but in order to do that, the specimens must be fixed in glutaraldehyde. Also, there are research assays which have been alluded to, including polymerase chain reaction in any fluid. Generally, the yield is pretty low except in synovial fluid, but it still is worthwhile doing because if you do get a positive, it can be very helpful. There's the Lyme urine antigen test. There's the beryllial immobilization test that Dr. Schell referred to. There are available presently only in a research setting are Lyme-specific immune complexes in both blood and spinal fluid. This has been pioneered by Drs. Coyle and Schutzer. And also ELISA capture OSP-A and OSP-B antigen detection CSF. As far as I know, the only person who's doing that is Patricia Coyle at Stony Brook. Also not to be neglected is direct culture in BSK. Again, very low yield, but if you are able to isolate the organism in culture, it is extremely helpful. I also want to mention spinal fluid examination. Whenever you have patients who are showing neurologic symptoms, spinal fluid examination ought to be considered. We have a low threshold for doing spinal fluid examination in our practice and encourage the patients to agree if they're willing, although we usually don't coerce them into having a spinal tap if they don't want to have it. When you do spinal fluid examination, it's important to do paired ELISAs and paired Western blots in both serum and CSF, to do a multiple sclerosis panel, cytology, because often with Lyme you will see reactive lymphocytes in the spinal fluid. Cell count and differential, glucose and protein, VDRL, CSF viral culture, and if appropriate, viral titers. PCR for detection of B. burgdorferi specific DNA. If available, Lyme-specific immune complexes in the spinal fluid, and OSP-A and OSP-B antigen detection. We usually take off quite a bit of spinal fluid, and we usually save the excess indefinitely in our freezer for the time when our gold standard test for Lyme disease eventually becomes available. It needs to be a non-cycling freezer, otherwise the specimen may be degraded. And also, I didn't put down on that list, but very important to culture for B. burgdorferi in the spinal fluid using Barbara Stoner-Kelly medium. Other useful adjuncts that we have found extremely helpful in evaluating patients with late Lyme disease includes MRI of the brain SPECT scanning, detailed neuropsychological testing, and when indicated, nerve conduction studies and EMGs. I want to move on to approach to treatment. One thing I'd like to emphasize is that a cookbook approach to treatment is absolutely inappropriate, in my opinion, in later Lyme disease. This is an illness with a very difficult bacterium that we are only beginning to fully understand and which seems to have quite complex life cycle and in which there is now abundant evidence in the worldwide peer-reviewed literature of the failure of short-term treatment. Thus, duration of treatment should be based upon clinical response as in the treatment of any other illness or infectious disease. In most instances, even in disseminated disease, oral therapy, a trial of oral therapy is appropriate because many patients, I would say the majority of patients, even with disseminated disease and even with neurologic involvement, can be well treated and can improve with intensive oral antibiotic therapy. However, there is a subset after one has given a reasonable trial of intensive oral therapy, or on the other hand, if they are so desperately ill that it's obvious that they need intravenous antibiotic therapy at once, there is a subset who do require intravenous antibiotic therapy, and in some cases that may need to be prolonged. Careful periodic assessment of the patient by the physician is essential, and several months of treatment, regardless of the mode of treatment, may be necessary to assess response to therapy. There should be undertaken a full discussion of the risk versus benefits of treatment, of intensive antibiotic treatment versus the risk of not treating what can be a chronic spirochetal infection. There needs to be careful periodic monitoring of the patient to detect any adverse consequences of antibiotic therapy. We usually do a CBC chem profile and urinalysis monthly to quarterly depending on the agent. It is very important to pay attention to gut hygiene with acidophilus taken usually 2 hours following oral antibiotic dosage, and it's important to anticipate the possible complications of oral antibiotic therapy or even intravenous antibiotic therapy. That is, to be aware of the possibility of C. difficile colitis, yeast overgrowth syndromes, and take appropriate diagnostic and therapeutic measures. As far as oral antibiotic therapy, there are basically several classes of oral antibiotics that are useful in treating Lyme disease. The tetracycline class, the penicillin class, including amoxicillin. And also I didn't mention as another method of treatment, which we have found quite helpful in some patients with chronic or late disseminated Lyme disease, and that is long-acting benzathine penicillin by injection has been very helpful to many patients. Cefuroxime and the azolide class. I don't think I want to belabor the different drugs and the dosages that's available. Also, again, although I don't think there's not very much in the literature, some of us clinicians have resorted to combined oral antibiotic therapy, such as amoxicillin and tetracycline class drugs, amoxicillin and an azolide, or cefuroxime and a tetracycline class or azolide. As far as intravenous antibiotic therapy, the classic agents that have been used are ceftriaxone and cefotaxime. We have used other agents. We have found Primaxine or imipenem-silostatin to be very highly effective, and we've actually seen fewer complications with this agent than with some of the cephalosporins. One can use doxycycline intravenously if the patient does not tolerate adequate doses of doxycycline by mouth. Occasionally there has been a role for vancomycin. Also now Zithromax or azithromycin is available as a parenteral agent. And one can use ampicillin. And one also can use penicillin G, which has the advantage of being quite inexpensive in a dosage of 12 to 20 million units per day. I also want to take a moment to discuss the role of an empiric diagnostic and therapeutic trial of treatment in patients who may have Lyme disease. It certainly is important to be thorough in evaluating our patients and do our best to try to make sure that we are not overlooking some other treatable diagnosis that is not Lyme disease. However, in my experience, even after very careful evaluation, one may be confronted with a patient who clinically has a syndrome that may fall within the spectrum seen in Lyme disease, yet one is not able to derive conclusive proof of the diagnosis. In that situation, in my opinion, an empiric diagnostic and therapeutic trial is essential and offers the patient the opportunity of a trial of treatment rather than just sending them away and telling them, well, I don't know what you have, come back in a year. Also, as far as monitoring response to therapy, especially with prolonged treatment, it's very important to have meticulous clinical assessment and reassessment. One needs to listen to the patient's subjective report of their response, perform physical examination, and when appropriate at timely intervals, if you have abnormal tests to begin with, do serial neuropsychological testing, serial Western blots, because bands can evolve on a Western blot, actually typically will evolve on a Western blot over time, and we have had patients where it's taken many years to evolve from one or two highly suspicious bands to a fully diagnostic Western blot. Sometimes we've had patients where it's taken more than a decade. Also, there's a role for serial direct antigen detection methods, particularly at the time of clinical relapse. There's a role for serial MRI, serial SPECTs, nerve conduction studies, and EMGs, because these can often show improvement. And also, if you have perturbed CSF parameters at the outset, it is definitely warranted to serially repeat cerebrospinal fluid examination during the course of treatment if the patient will allow. Taking care of patients with disseminated Lyme disease can be quite a difficult task. These patients are very challenging, can be very taxing. However, it can be very gratifying to be able to help these patients. Thank you very much.
Thank you, Dr. Liegner. Our next speaker is Dr. Brian Fallon from the Columbia Presbyterian Hospital, New York State Psychiatric Institute. He's going to talk about a new area that's really coming to light in Lyme disease, and that's the neuropsychiatric manifestations. Dr. Fallon.
Thank you very much. I'm going to talk about the neuropsychiatric aspects of Lyme borreliosis. I always like starting with a case, so I'm going to present one case, and this is of a 7-year-old girl who was initially misdiagnosed as having a developmental attention deficit disorder. However, she also had physical symptoms. She had fatigue, headaches, she was very sensitive to light and very sensitive to sound, and she was quite irritable. So because she lived in a heavily Lyme endemic area, her physician tested her for a variety of things, including Lyme disease, and she tested positive. And so she was treated with a month of oral antibiotics. Shortly thereafter, she relapsed and many of those symptoms returned. So the physician, the pediatrician, put her back on the oral antibiotics for maybe 2 or 3 months, and then she relapsed. And so he put her on eventually for up to 2.5 years of oral antibiotics. And she then did extremely well and was perfectly fine for 3 years. She went to Europe with her family, came back to Westchester, New York, and perhaps got bitten again, because then she started to have some of the physical symptoms again of headaches and joint pains and fatigue. Her parents were quite alert to this. They brought her into the pediatrician. He found that she tested positive for Lyme disease again. He treated her with Ceftin for 2 months. She did very well, went back, was in school doing fine, and then after the antibiotics stopped, she started to show problems with attention and concentration in school. So this is an A+ student, a really bright young girl, and her teachers reported that she was inconsistent, disorganized, careless, her head was in the clouds, she was scattered, she'd forget where she put her completed homework, and she'd have no memory of whether she had actually done the homework at all. Physically, she was noise intolerant, irritable, she had knee pain, frequent headaches, paresthesias, and mild fatigue. We did neuropsychological testing 4 months off of antibiotics, and she had deficits in planning, visual memory, and visual tracking. And so here was a child who clearly had a variety of neuropsychological and physical deficits that were highly suspicious and suggestive that the Lyme disease was reemerging, so she got placed once again on antibiotics and went back to being an A+ student, and her teachers were no longer commenting. Now, I want to briefly touch on the relationship between Lyme disease and syphilis, because both, as you know, are caused by spirochetes. Both have an early localized skin reaction. Both can cause a multi-system illness. Both rapidly invade the central nervous system in the case of Lyme disease within perhaps 2 weeks of skin inoculation. Both can cause a wide spectrum of neuropsychiatric manifestations. Both may manifest with a Herxheimer reaction, that is, an initial flare of symptoms shortly after antibiotics are started. And both can have a latent asymptomatic infection where the person may get bitten one summer and not develop symptoms of disease for a year, 2 years, or even 10 years later. Now, syphilis is well known to have a large variety of psychiatric manifestations, including memory problems, depression, mania, psychosis, personality changes, and even psychiatric Herxheimer reactions, where a patient who was not psychotic was treated with antibiotics and then developed psychosis who had neurosyphilis. By the conclusion of my talk, I will hope that you will come to conclude that perhaps Lyme disease can cause a similar array of neuropsychiatric problems. Now, you've already heard about early localized and disseminated Lyme disease. In early neurologic Lyme disease, oftentimes you see severe headache, you may have meningitis, cranial nerve palsies, radiculoneuritis, where you have these shooting pains or stabbing pains. You may have a mild encephalitis where the person is emotionally very labile, or they're confused, they may get lost in familiar places. And then later on in neurologic Lyme disease, the person may have encephalopathy. Now, what is encephalopathy? Encephalopathy really is a problem in cognition. It's a problem with perhaps memory or learning or verbal fluency, and oftentimes it's associated with irritability and sleep disturbance. Dr. Ligner talked about encephalomyelitis and chronic polyneuropathy. And sometimes, unfortunately, as I'm sure Dr. Donta will talk about, patients develop chronic Lyme disease, and some are responsive and some aren't to antibiotics. Now, the test for early central nervous system Lyme disease, in a situation of meningitis or encephalitis, the CSF will often show a mononuclear pleocytosis or mildly increased protein. Intrathecal antibody production in the case of meningitis is reported to be found in 70 to 90% of the cases, but that's in meningitis. The MRI studies may show punctate white matter lesions, and sometimes the EEG will show diffuse slowing or epileptic discharges. This is early neurologic Lyme disease. And here's a slide of an MRI of a 10-year-old girl who had optic neuritis and foot drop. And here you see that white matter lesion, that bright hyperintense lesion, that after treatment went away. And that's oftentimes seen with the white matter hyperintensities in Lyme disease, that after antibiotic treatment they go away. That can be very helpful because these white matter hyperintensities often look very similar to the demyelinating-like lesions that you see with multiple sclerosis. So if after antibiotic treatment they go away, that would be highly suggestive that this is Lyme disease and not MS. Dr. Coyle and Dr. Schutzer published in the journal Neurology in 1995 a study of 35 patients with late neurologic Lyme disease who had Bieberdorf-free OspA antigen in their CSF on the immune complex assay. So these were patients who had definite CNS Lyme disease. Of those patients, 43% had normal CSF antibody studies. So if you're relying on the Lyme antibody studies in the CSF, only 43% of the patients with clear neurologic Lyme disease will have normal CSF antibodies. No evidence of it. 20% had no evidence of either the antibodies or elevated protein or white cells. So basically what that proved was that a normal CSF cannot be used to rule out active neurologic Lyme disease. Spinal taps are very important, primarily to exclude other diseases, but they cannot be used to rule out active Lyme disease. So to review, the tests for late CNS Lyme disease, MRI and EEG studies are generally normal. In fact, only about 20% of the time you see abnormal MRIs in Lyme encephalopathy. Neuropsychological tests, as Dr. Ligner referred to, often reveal abnormalities in learning, memory, concentration, mental tracking, and conceptual flexibility. Insurance companies and doctors like to see something objective, so neuropsychological tests can provide objective evidence of cognitive abnormalities, and they can be used to document where you are at one point in time and then after antibiotic treatment, whether in fact you have improved. SPECT imaging I will talk about shortly. So faced with this array of negative tests and not very helpful tests, really what do you need to know? You need to know the clinical symptoms. So the common symptoms of late neuroborreliosis we've talked about, but I'll review: fatigue, headaches, lighter sound sensitivity, word finding problems, short-term memory loss, cognitive tracking deficits where people can't keep focused on one thing for more than a second and they're constantly moving from one idea to another. They can't complete tasks. Geographic disorientation, dyslexic type errors, tingling, numbness, fasciculations, shooting pains, irritability, mood lability, depression, and insomnia. Now, if you look at the peer-reviewed literature, you find that there have been reports of Lyme disease being associated with a very wide array of psychopathology. Major depression, primarily agitation and irritability, obsessive-compulsive disorder, panic attacks, depersonalization. That's what's generally their patients refer to as their Lyme fog. That's depersonalization. They feel spacey. Anorexia nervosa has been reported, disorientation, violent outbursts, personality changes, and rarely, but it has been reported, true dementia-like syndromes. Now, we did a survey of patients with chronic Lyme disease and compared the results to patients with arthritis and lupus, and what we found was that the Lyme disease patients reported experiencing major depression 3 times more frequently during the course of their illness than did the patients with arthritis or lupus. It suggests that, in fact, the depression or irritability, therefore, is not just related to pain, because otherwise you would expect similar rates with the arthritis patients, and not just related to having a fluctuating inflammatory illness, because otherwise you would expect a similar rate with lupus. So there may be something specific to Lyme disease that induces a depression or agitated depression-like picture. Panic attacks were also significantly more frequent, and in my experience it's more common that really severe prolonged panic attacks occur early in the course of illness. Now, what is the role of SPECT imaging, and does it have a role in neuropsychiatry? Well, it's been found to be very helpful in unipolar depression. typically you'll see decreased perfusion in the inferior frontal lobes, the middle two SPECT scans. Look at the bottom. If someone has Alzheimer's disease and they're depressed, you'll see the same decreased flow in the frontal lobes on the right, but you'll also see decreased flow in the parietal area up on the top of the lower right-hand image. Now that's classic for Alzheimer's disease, to see temporal parietal decrease, and for depression to see frontal decrease. So what do you see if you look at SPECT scans of patients with Lyme disease? Now with Lyme disease on the left and a normal SPECT scan on the right, what you would like is to have a whole nice wide array of yellow, which indicates normal perfusion throughout your cortex, as you see in the right set of images. On the left you see lots of red and green, which is demonstrating decreased perfusion or decreased metabolism. You also see what look like large ventricles in the left compared to the right. That's the inner portion of the image there. And in fact, because this patient's MRI scan was normal and did not show enlarged ventricles, we know that this patient in fact did not have large ventricles, but in fact had white matter disease. And in fact, our SPECT studies of Lyme patients and SPECT studies being done in other groups confirm that it seems to be primarily a white matter disease. Oh, thanks. In a series of patients at the Columbia Presbyterian Medical Center that we looked at who came for evaluation with SPECT imaging of their chronic Lyme disease, 70% of the Lyme disease scans were abnormal. And of those that were abnormal, the pattern that was most common was a heterogeneous pattern of uptake. Heterogeneous means diffusely patchy uptake. Some areas were normal, some areas were decreased. Eric Logigan and Steer up in Boston reported in December of '97 a very similar finding. What they found was that indeed there was cerebral hypoperfusion of a patchy heterogeneous type in Lyme encephalopathy, and that it was reversible, or at least partially reversible, after antibiotic treatment. Now I want to emphasize, as you can see on this slide right there, that of the 13 patients with clear Lyme encephalopathy, 8 of them had intrathecal antibody production or a positive PCR, and they were selected for that. But 2 of those 8 patients were completely seronegative, and 4 of those 8 had equivocal ELISAs or Western blots. So here were patients with definite Lyme encephalopathy, as noted by Logigan and Steer, who were seronegative or equivocal in their tests. Only 2 of those 13 patients had abnormal MRIs. What they found was that the decreased perfusion, and the higher up the worse perfusion, improved after being treated on all 13 of those patients, including the seronegative and the seroequivocal patients. But it didn't completely normalize. What we don't know is if they treated them for more than a month, would they have gotten even further better? And if they had treated other patients, whether they would get better, some of the patients who they said had possible Lyme encephalopathy. Now, there are a variety of causes of multiple regional SPECT perfusion abnormalities, not just Lyme disease, and you need to know this. Systemic lupus, cocaine abuse, chronic cocaine abuse can do it, multi-infarct dementia, chronic fatigue syndrome, AIDS, and now Lyme disease. Now I'm going to move to talking about children a little bit. In a series of patients who were referred to a pediatric neurologist at Stony Brook, Anita Bellman, she reported that 71% of the patients had headaches, so that was the most common symptom. The second most common presenting complaint, however, were behavioral or mood changes. So here's a clear demonstration in a neurologist's practice that psychiatric problems were a very common manifesting problem. In fact, in looking over time at a large number of children who we've seen at the New York State Psychiatric Institute in New York, most commonly among the children, we saw attention deficit-like syndromes, chronic fatigue-like states where they'll be falling asleep in class, mood disorders where they'll be very irritable, labile, or just kind of low-grade down, depressed, or they'll develop new-onset phobias or fears, with suddenly emerging at the age of 12 with separation anxiety or over-anxious disorder, and some of the kids become quite hostile, irritable, impulsive, and appearing to be quite oppositional. Less commonly, but definitely reported, are Tourette's-like disorders in the Lancet and early in last month's Lancet, There was a case reported of new onset Tourette's after Lyme disease that resolved with the treatment of the Lyme disease. OCD has been reported, anorexia nervosa, psychotic disorders, conversion disorders, pseudo-psychotic disorders, because these children aren't being believed, so sometimes they have to elaborate their symptoms to get doctors to believe that in fact there's something wrong with them. And rarely, but I have seen a patient who developed what looked like autism, and then about a year later, after the severe autistic-like state, developed a Bell's palsy, and they worked the child up for Lyme disease, and the child was sero and CSF positive for Lyme disease, got treated with 6 months of IV antibiotics because 1 month didn't do anything. And after 6 months, the child was 85% better, and the child is now back in school and doing remarkably better, no longer is autistic. In looking at 21 children who came to us with chronic Lyme disease, a third of them were currently depressed, and more than half had suicidal thoughts. 1 out of 2 of the kids in that sample had made a suicide attempt or gesture. So it's very important to give these children support, to be aware that they can get quite depressed, they feel socially isolated, they're withdrawn from school, and they need both the pediatrician's attention as well as a psychiatrist's attention, as well as strong connections with the school. Now, if you look at the criteria for attention deficit hyperactivity disorder, in particular the inattentive subtype, you see that this is true and common among patients with adult Lyme encephalopathy and children with chronic Lyme disease. Careless mistakes, difficulty sustaining attention, seeming not to listen, failing to finish tasks, trouble organizing themselves, avoiding tasks that require sustained attention, perhaps like paying bills, losing things, easily distracted, and quite forgetful. Now, I'm not trying to say that all psychiatric problems are Lyme disease, because obviously they aren't. So when you have someone who you think may have psychiatric problems related to Lyme disease, you need to look for a history of erythema migrans, you need to look for suggestive or positive serologic tests, tick bite and exposure to an endemic area, look at their neuropsychological test results, look for joint swelling or migrating arthralgias, look for signs of central or peripheral neurologic disease, look for a history of cardiac or ophthalmologic problems, and look to see if they have been treated with antibiotics, did they get better? And did they get worse initially, which would suggest a Herxheimer-like reaction, which would support the diagnosis. Now, I only have 3 more slides. How do you treat these patients? Well, we looked at 22 previously treated patients with chronic Lyme disease. They had, as a group, they had a mean of 1 year of oral antibiotics and 9 weeks of IV antibiotics before coming to see me. And as it turns out, after being retreated with antibiotics, tested at baseline and then 4 months later, they showed significant improvement in verbal IQ, performance IQ, verbal memory, visual memory, general memory, attention concentration, and delayed memory. These are objective neuropsychological tests on which they showed improvement. This was not a randomized controlled trial, but it's very highly suggestive and supports the community physician's observation that repeated antibiotic treatment often is very helpful. Psychopharmacologic strategies can be very helpful as well, in particular with people with residual symptoms. So if someone has residual attention, you might try treating them with Wellbutrin, which is bupropion, or Ritalin, which is methylphenidate. Fatigue can be helped with antidepressants, again bupropion or diazepamine or fluoxetine, which is Prozac. Fibromyalgia can be helped with amitriptyline or Paxil. Sound sensitivity, that incredible hyperacusis that these patients can be profoundly debilitating, and that can be helped with things like Tegretol or clonazepam. Nerve pains can be very helped by tricyclics. Anxiety, obviously, typical anti-anxiety meds, and mood swings can be helped with the same meds that help bipolar disorder, valproate and Tegretol. The clinical experience of Lyme disease is one of a fluctuating symptom pattern, uncertainty as to diagnosis and treatment, worsening symptoms when they're getting treated, bizarre symptoms, economic stressors, and then they're the focal point of a medical controversy. What an awful disease to have. It can cause tremendous psychological distress as well as organic psychiatric distress. And finally, the great American physician, Sir William Osler, said, the greater the ignorance, the greater the dogmatism. And we should remember this because at this point in history, we do not have adequate serologic tests, although they're helpful, and we do not know what the proper guidelines are for treatment in terms of the exact length of treatment and the exact type of antibiotic. We know some, but we don't know enough. Thank you.
Thank you, Dr. Fallon. Our last speaker is Dr. Sam Donta, Chief of Infectious Diseases at Boston University, and he will talk about refractory Lyme disease. Dr. Donta.
I'd like to thank all the organizers of the conference for asking me to come here and discuss some aspects of Lyme disease. The title, Refractory Lyme Disease, could be retitled as Chronic Lyme Disease, Where Are We and Where Are We Headed? And I hope my comments will build on those of the previous speakers. I will take the liberty of trying to explain some of the underlying mechanisms, speculating, some drawing from other infectious disease examples, in order to try and build a rational picture of what explains some of the symptoms and some of the difficulties that we've had in the diagnosis of Lyme disease and in the treatment issues as well. One of the issues that we've had is, are the patient's symptoms really due to Lyme disease or some other disease? Is it due to persisting infection, or is it due to some residual damage, be it an autoimmune type of damage, or are there other mechanisms involved? The other speakers have emphasized how there is a differential diagnosis to be involved. Let me put the first slide here. And as part of a survey that we had conducted, we had asked people, what do they think of fibromyalgia and chronic fatigue? Is it due to Lyme? Is it a separate entity? And you can see is that we're probably all over the place. And that some physicians felt it was indeed a separate entity, and other physicians felt that it was a result of Lyme disease, and others felt that it was possibly both. With chronic fatigue, it was welcoming to hear Dr. Strauss at the last conference on Lyme borreliosis in New York, when he addressed the entity of chronic fatigue and Lyme disease, to say that there was serious overlap between the two diseases. So for now, to get a diagnosis of fibromyalgia or chronic fatigue, I think is to get a descriptive diagnosis, which is helpful in part to say that you have something, but it does not allow us currently to distinguish between whether the fibromyalgia is a separate entity, is a post-Lyme entity, or is really Lyme disease very much disguised because of our shortcomings in being able to diagnose it. Other entities that could be put up here as well have been discussed, multiple sclerosis. Let's put Gulf War syndrome in this as well. And one of the difficulties, again, that has been previously discussed is a credibility issue. Can you really believe the patient who comes to you and has all this multitude of symptoms, and they really have something wrong with them, when you have so little on physical examination to go by, and the testing is somewhat problematic. In trying to discern what might be some of the factors responsible for the chronic and the refractory disease, you look at regular infectious disease aspects and try and figure out what are the determinants of the infectious outcome. The inoculum size initially might be important in how much of an immune response you get and how much disease you eventually get. Antigenic variation has now been shown with Borrelia species and Borrelia burgdorferi, and the OSP-C outer membrane protein is especially variable and can shift antigenically. It might be like one of those Romulan vessels that cloaks themselves as it goes ahead into the neurologic site and finally hides so that the immune response has not been able to be generated. What are the real target cells for this? My own view is that the nervous system, the neurocells, explains the entire picture. It may be that some synovial tissue, some synovitis may be part of it as well, but I think the neurologic system is clearly involved in the most appropriate animal model thus far. The monkey model seems to validate that observation. If this is an intracellular infection and localization, and I don't know of any other infectious disease that is chronic that is out in the open. The trichinella, the trichinosis, can form a calcium shell around it in order to hide, but I'm not aware of other infectious organisms that can cause a chronic disease and stay out in the open where you have patrols, you have white cells, you have filter systems, you have the immune system. Inside an intracellular location, and my suspicion is that it's in a glial cell or the neural cell itself, or perhaps an endothelial cell of the blood vessel serving the nervous system, it can hide quite nicely in there and escape the humoral immune system, if not the cellular immune system. Host factors are undoubtedly important, and we have a long ways to figure out which of these are relevant in the development of the chronic Lyme disease syndrome. There may be some HLA-type specific responsiveness to some of the antigens that may help to determine arthritis in a particular individual. But it's certainly not one factor at this point that allows us to understand why patients develop this chronic convoluted type of disease. Are hormones important? I'll come to that in a minute. And are cytokines important? That too. But one of the things that attracts me is the role of toxins in this Lyme disease. It strikes me that taking the lessons from tetanus, where you have a hyperthyroid type of state during tetanus intoxication, and the explanation, while not completely validated, is that your beta-adrenergic receptors have been upregulated by the tetanus toxin, and you get a thyroid storm or thyroid-like hyperthyroidism, again associated with an upregulation of beta-adrenergic receptors, is a tempting analogy for me, because we have a variety of sensitization of the adrenergic system and of the autonomic system, the palpitations, the sweats, the flushing scenarios, the abdominal complaints. So that's one toxin that I think is an interesting one. Its very close partner, botulism, is another interesting neurotoxic disorder. There you have the same final mechanism on the acetylcholine receptors, or the release through a calcium channel intervention, but a completely different set of events where you get a flaccid paralysis in that case. Diphtheria toxin is a neurotoxin, and the consequences of that are uncertain, but if these organisms produce a diphtheria-like toxin, it could be that there is permanent residual damage to the nervous system. Now, because so many patients seem to reverse their abnormalities, my assumption is that this is not a permanent type of damage. But I cannot fully explain why a good 10 to 20% of patients with chronic Lyme disease, seropositive or seronegative, who've had the disease for a very long period of time, don't seem to respond to any antibiotic therapy. Do they now have some other disorder, some Lyme-like disease that we have yet to discover, or have they proceeded to some form of residual damage that we do not have any currently available methods to treat this? To take the example of tetanus, you don't have to really see the specifics on this slide, but to show you that things in nature can mimic natural mammalian mechanisms. For example, tetanus toxin binds to the brain tissue and binds to thyroid tissue in similar fashion, and it can compete with thyroid hormone, thyrotropic hormone. So there is some similarity between these two seemingly completely different substances. And it's my opinion that we will find finally some overlap between some of the toxins that are produced. Indeed, we now have 3 different toxins that we have uncovered from the Borrelia burgdorferi, one of which is makes a hybrid cholera and diphtheria toxin activity. We are working on another one with a combination of pertussis type of activity, and we're in the process of trying to clone the genes responsible for what, by DNA analysis, looks to be a tetanus or botulinum sequence. So if we can go ahead and proceed and discover some of the underlying mechanisms responsible for this, we can envision a day where maybe a vaccine can be made against the virulence factor itself, much like what you have when you have a tetanus shot. And it doesn't really matter when you step on a nail or you get tetanus inoculation, you won't get the disease because you have antibodies against it. I don't know what that says for somebody who's already sick with the disease. Can you devise a strategy that would be effective versus the passive antibodies? The role of cytokines and hormones in Lyme disease is speculative. It's fascinating to me that glial cells make progesterone and metabolize progesterone. Now here's a nerve cell, and we don't quite understand why that's to be the case. But would that have a bearing on the cycling, especially in women who notice premenstrually that there's an increase in the symptoms? And that's been something that we've been accustomed to saying, well, that's PMS, or that's something, and is it caused by chlamydia, is it caused by depression, a variety of things that we speculate about, but could it indeed be something that is related to a hormonal balance that could affect the intracellular activity of an organism? We know pretty much that herpes genitalis can be driven by cycling symptoms, especially menstrual cycles when it recurs, and we know that the herpes viruses live in sensory ganglia. And again, my view of this is that this too occupies primarily sensory ganglia along the roots throughout the spinal cord, and in the brain it's speculation as to where they are. We don't have, again, the evidence, but the listening to patients and trying to ascertain what their symptoms mean, you can begin to construct some scenarios as to what might be important. The NIH is looking very much at cytokines, and I think it'll be very important to see whether the Borrelia produce substances that mimic nerve growth factor, for example, or ciliary neurotropic factor. It's fascinating that in ciliary neurotrophic factor, which is a cytokine, it's not one of the better known ones, but it was developed into a potential therapeutic agent for one of the neurologic diseases. And interestingly enough, when patients got that, 50% of them had an outburst of herpes simplex labialis. And so somehow this particular cytokine, a natural substance found in the body, modulated the intracellular dormancy of the particular virus in that case. The Borrelia, as Dr. Ligner said, have been demonstrated to be intracellularly in vitro models, and we have yet to demonstrate that intracellularly. So where's the bug? To paraphrase Dan Ron's article on where's the bug, your choice is to say it isn't there because we can't find it, or our tools are yet sophisticated enough to find it, patients are depressed and that explains everything, or that it really is there and it's not replicating very much. And I think that's probably what the scenario is. If it was really replicating very much, the cell couldn't hold on to it very much, and then some of the DNA should come out into the spinal fluid, or more likely the brain, and into the urine. And as specific as the PCR DNA technique is, it's not quite as positive as we'd like it to be. Maybe some advances will allow us to see it. I'm not precluding that there aren't periodic release of antigens from infected cells, or even including the DNA, but currently I'm unimpressed that the PCR DNA positivity is sufficient. And there are other infectious disease models, herpes encephalitis for one, which is associated with PCR DNA positivity for only a short period of time, and then you no longer detect the DNA of the herpes virus in blood or spinal fluid, even though you know it's there. So the PCR DNA is only as sensitive as the material being released, and if this bugger wants to stay inside cells, then that's where it's going to stay, and it may be content to live out its life producing things like toxins, which are extremely potent. For example, the tetanus toxin is one that is so potent and is produced in such small amounts of material that the immune response does not recognize it. So if you have tetanus and you get over it, you need to be immunized. In other words, you haven't developed natural antitoxic immunity. This applies to botulinum and to staphylococcal toxic shock syndrome. The women who typically had those, especially when they went through that era of the new tampons that were associated with it, typically would get it over and over and over again for a number of cycles, and again, because the toxins are so potent and produced in such small amounts that they may not be immunogenic, or they may be able to trick the immune system. Where's the bug? Is it like the zoster virus living in the dorsal root ganglia? Does it live out in the skin? Does it come out periodically? What happens when you get the Lyme lesion to begin with in the bacteria? You probably put into play all kinds of neurologic mechanisms, and we have to hone in and find out, because serotonin is involved in this disease. Just listen to the patients. Histamine is sometimes involved in a disease. Prostaglandins don't seem to be very much involved in a disease. Advils and Motrins and ibuprofens don't really seem to do a whole lot in this disorder. Substance P is one of the ones that we're going to try and hone in on, because that's an important pain factor that's responsible. There are other, if you look at all of the various arrays of what the neurologic systems are and feedbacks and secondary compensatory systems, it's quite complex, but I think if we systematically look at these, we will be able to simplify them to some degree. What about immunity? What is up with that? I mean, are you going to develop good humoral immunity or not? That taking the typical Th1, Th2 model of are you doing more cellular immunity versus more humoral immunity, that's unknown. I'm unimpressed that these bacteria in general promote a very potent immunologic response. I don't know why the chronic arthritics have a very high response. Again, that may be an immunologic genetic response, but most people do not produce a lot of humoral antibody. That may be, again, its intracellular localization or its ability to shut off some of the immune response. Cellular immunity is not a big player in this, although it hasn't been adequately investigated. I view the immunity as being primarily what I call a nutritional immunity, an intracellular one, where the host tries to starve the bacterium out. That's why I'm kind of careful with all these supplements. I think that I become a minimalist, and you want to be awfully careful as the body tries to deal with intracellular parasites. We know from chlamydia that if you provide tryptophan, you can go ahead and overcome the block in the tryptophan pathway that the body has induced to try and control that intracellular pathogen. As far as the immunity, this has been discussed in our studies, our Western blots. Our ELISAs were negative in most of the cases in which our Western blots were positive, both by standard criteria. So I don't even do the ELISA anymore. I only do Western blots, and I use my own interpretation, which is that any specific band plus one other band that is specific or non-specific constitutes evidence of exposure to the Lyme bacteria. That doesn't mean that that's correct, but it means that our ideas about what the Western blots and what the ELISAs are doing, I think need to be rethought. In fact, in some of our studies, we found that the IgM blots were the ones that were positive in chronic active disease, and that makes sense. IgM is not just an early response, but it's also a relapsing or reactivating response, and with successful treatment, that IgM response generally dissipates. This also is interesting that when you look at the results of our tetracycline studies, that whether you were seropositive or seronegative, your outcome was somewhat similar. In fact, the seronegatives probably did better than did the seropositives. But these are issues that need to be further studied. As far as the duration of antibiotic therapy, it's been said that we do need longer. This is a big discussion, a point of contention, and clearly trials need to be conducted. This is a survey of what doctors have been using. I myself prefer to use intracellular type of antibiotics, and the lesson that I learned from the tetracycline studies that we did is that the prior duration of symptoms, if you had it for less than a year compared to if you have it greater than 3 years, determines whether you're a cure, an improvement, or a failure. And the onset to improvement is greater the shorter you've been sick before, and it's harder to get improvement with longer disease. With continued treatment, and this is our tetracycline result, you continue to improve from the second to the third month, And even with retreatment courses, retreatment course with tetracycline, with intravenous antibiotics, and with macrolide with a lysosomotropic agent. I don't have time to talk about that here. We will discuss that in New York at the Lyme disease conference on how those agents help macrolide treatment. So in summation, I think that we've learned a lot. I hope we can get over the idea of whether patients have this disorder or whether they have another disorder as part of the differential diagnosis that you think about, and we need to conduct some further clinical trials and pathogenesis trials. Thank you.
Thank you very much, Dr. Dante. We only have a minute to go, so I'd like to thank everyone here in Chicago, our supporters, our hosts. And I'd like to remind you, the Lyme Disease Foundation's conference is on April 25th and 26th in New York City. Visit our website at www.lyme.org for further information. I think we've achieved our purpose of educating and increasing awareness here, and I thank you all very, very, very much. Have a good day.
You look like I feel.